Thank you, guys.
Thank you, sir. Hello, everyone. I am Dr. Amit Bandwal from Gen Physio. So today I'm going to take a topic like intricate connection between the scapular dyskinesia and the cervical spine. So under the supervision of Dr. Tejinder Singh and Dr. Steve Ford, I am going to conduct one-on-one lecture. So we are Gen Physio, like global initiative for the expert manual therapist. So this is the team. You can connect us at Instagram, Facebook, WhatsApp, or you can mail us as well. So these are the two diligent and dedicated mentors of Gem Physio. They are trying hard and take out the best from us, giving a lot of information with latest scientific evidence. So the content of the slides are presentation is scapular joint, muscular attachments, motions of the scapula, biomechanics and orthokinematics, scapular dyskinesia, types and tests for the scapular dyskinesia, what are the common nerve involvements, some latest research articles, and treatment and exercise plans. And one more, picking one muscle among all the attachments in a scapular bone. So let's start. So what are the joints scapular bone forms? It forms two major joints like glenohumeral joint and acromoclavicle joint. It also forms a joint between the thoracic wall and the scapular anterior surface. It is a pseudo type of joint, not an exactly true joint. There are a lot of muscle attachments. So anybody would like to take a try that how many attachments are there in a scapular bone? How many muscles attachments it is carrying on? If anybody wants to take a try or give a shot before we move on. Anybody?
Any guesses, guys? How many muscles
guesses?
attached to the scapula? It's kind of interesting trivia question. 16, you're very close.
18 is also close.
You guys are close. 14.
The exact number is missing actually.
Yeah. So the exact number is 17.
Yeah,
you
17. Yes, Akila, yeah. This was good, right? So the number of muscles attached to the scapular bone is exactly 17. So just we'll have a super view over the muscles, how these muscles are attached to the scapula and in what area. So just have a look. So these are the stabilizers of the scapula. What are the muscles like levator scapulae, rhomboids minor, rhomboids major, and trapezius. These are the four muscles which are acts basically stabilizers of the scapula. Next. These are the other four important muscles. One is the short head of the biceps. We know that the short head get attached to the coracoid process. And the long head of the triceps is also have a attachment to the lateral border, superlateral border of the scapula. Omohyoid is also having attachment. This muscle get from the hyoid bone to the superior border of the scapula. And we know that posterior and middle fibers get attached to, and the deltoid of posterior and middle fiber get attached to the spine of the scapula and the acromion process. Next, there are teres major, centeris anterior, coracobrachialis, and pectoris minor. These are the four important muscles known as rotator cuff muscles. They are like supraspinatus, infraspinatus, teres minor, and subscapularis. Last but not the least, latissimus dorsi. As we can see that this is a broad, flat, triangular shaped muscle covering the most portion of the back of the trunk and having a very small attachment to the inferior angle of the scapula. So just we move on. Now, what are the motions of the scapula? Just I will try to demonstrate Just consider this two scapula of mine. This is, I'm going to keep it fixed to just have a comparison between the motion of the both scapula. For elevation, how does it go? We just elevate upwards with a slight rotation. And for depression, it goes downward. I hope I'm visible.
You can pin Dr. Amit's video just to make sure that your focus is on him.
And for adduction or retraction, it goes like towards the midline of the spine. And for the opposite movement, like abduction or protraction, it goes away from the spine. And for upward rotation, it goes towards outside or upward. There's more of like rotation outward. And for the downward, it's just reverse. It gets towards the mid of the spine. Moves towards the, or rotates towards the mid of the spine. I hope you all get it. I hope you all can get it. So just we are moving on. What are the range of motion of the scapula? For elevation, we get 40 degree of motion. For elevation, 40 degree. For depression, it's 10 degree. For protraction, it is 20 degree. And for retraction, it is 15 degree. For external and internal rotation, it is like 60 and 30 degree respectively. So just a moment, please, guys. So what are the movement of scapula or plane of movements of the scapula? Just I'll try to demonstrate the motion. For the horizontal axis, we are getting upward and downward motion, like upward and downward. And for internal and external rotation, it is also on vertical axis, like this. This is internal rotation, and this is external rotation. And there is a transverse axis for the anterior and posterior tilt. It looks like this is like anterior tilting, and this is like posterior tilting. What are the coupling movements we get for the scapula? There is a, for retraction, it's a combination of 4 different movements. How come it looks like just retraction we count like this motion, but it comprises of 4 different movements. What are they? Like external rotation is moves like external. I'm just keeping this fixed to just have a comparison between the two motions, two scapular motions, right? So external rotation, posterior tilting, upward rotation, and medial translation towards the mid of the spine. I just try to demonstrate once more. For retraction, external rotation, posterior tilting, upward rotation, and medial translation. Just all together, it comes like, I hope I can you can get it.
That's very good, Amit.
Okay.
Dr. Amit.
And for protraction, it is just the reverse. What are the 4 movements we are getting it? Like internal rotation, anterior tilting, downward rotation, and lateral translation or outward translation. For protraction of scapula, how does it move? Internal rotation, anterior tilting, downward rotation, and lateral translation. I hope you can get it. Protraction all together. What is the next coupling movement? It is a like shrug, the elevation of the shoulder. It comprises of 3 movements. That is upward translation, like upward translation, anterior tilting, and internal rotation. It comprises of 3 movements. I just explain it once more. Upward translation, anterior tilting, and internal rotation, like this. Just it goes like this. If anyone wants to repeat any slide, just please let me know. Now, biomechanics and orthokinematics. We know that there is a traditional ratio we get for the scapulohumeral rhythm. It stands like 2:1 ratio. Basically, it is the combination of movement of glenohumeral and scapulothoracic region. So I think I have a video for you to visualize this. How does this move? Just let me play this video. As we see that initial 30-degree of motion, there is no movement of the scapula. As it moves ahead, it starts to move. It's a 30-degree. Now the scapula starts to move along with the humerus. For 50 to 60 degree, we get a 20 to 30 degree of motion of the scapula. For 110 degree of glenohumeral, we get around about 40 to 50 degree of motion for the scapular thoracic region. I will just play this once more. -30 degree of glenohumeral movement, and after that there is a scapulothoracic movement.
I think we have some issue here. I think Dr. Amit is logged out. I think Dr. Amit is trying to rejoin.
I'm sorry, guys. There was some technical glitch. Just a I'm audible, sir?
Yeah, just move on to the slide where you were showing scapulohumeral rhythm. Okay.
Okay, sir.
And make sure that we're recording this. Yeah, just demonstrate this one more time.
This one? This slide?
Yeah, this one. Yeah, I think people want to see this one more time.
Okay, sir. 30 degree of glenohumeral movement, and the scapula moves. So for 50, 60 degree of glenohumeral, we get 20 to 30 degree of scapulohumeral, and 110 we get 40 degree of scapulohumeral movement. So one more time, or that's fine?
I think
So
this is good. If you people want to see that again, we'll probably come back to the slide.
Okay, sir. So I'm moving on. So scapular dyskinesia, it was quoted by Kepler. Like this stands for the alteration of the movement of the scapular bone, and kinesis stands for the movement of the scapula. It is basically the movement or the alteration of the movement or malfunctioning of the scapula we get in a resting position of the scapula, or it will be in a dynamic motion of the scapula. Basically, we look out for the medial border prominence of the scapula, inferior border prominence. There may be a rapid downward rotation of the arm while asking the patient to put it down from the elevation. Generally, when we ask the patient to elevate the arm, it's fine, but while just asking the patient to put it down, it just fall it very rapidly. So this all counts in a scapular dyskinesia. There is a basically, it describes like the position of the scapula and pattern of motion of the scapula. It may be specific or non-specific. Generally, we get patient with the shoulder issues, specific shoulder issues. There may be non-specific cause of the scapular dyskinesia. It have a multiple factors involvement, like nerve injuries, maybe in the neck region, muscular weakness around the scapula, or in the AC joint, supralabral tear, or rotator cuff injuries at the top of the scapular region. It mainly also find that there may be some issues, imbalance, or pattern of activation may be reduced in the stabilizing muscle of the scapula. This study shows that when we get a patient for a retracted patient, generally this study was done by Kevlar in 2006, that when the patient get for a retracted position, there is increased activity or strength of the supraspinatus, which may be increased by 24% in the position of the scapular retraction. There was another study also done by Kebeste at 1999 with that when the scapula was excessive protracted, the strength of the rotator cuff muscle was reduced by up to 23%.
So, Amit, do you mind going back to the previous slide? Yeah. So I think this is a good study. If you're trying to rehabilitate supraspinatus, what do you need to work on? If you're trying to improve supraspinatus strength, what do you need to work on? You also need to work on scapular retractors, because if scapular retractors are weak, you're going to have like already resting altered strength of supraspinatus, regardless whether the patient has shoulder pain or not. Okay. Yeah. Thank you, Dr. Amit.
Okay. Thank you. So there is a classification by Kevlar. It has been divided in 4 types. What are the types? Like type 1 is inferior angle prominence. Type 2 is medial border prominence. Type 3 is excessive superior border elevation. And type 4 is like absence of scapular dyskinesia. Well, we have like symmetrical scapular motion. We can see this in these 4 images. In the first image, the inferior angle is more prominent. In the second one, that we have medial border we are having more prominent in bilateral. And in the third image, we get it unilateral superior border elevation in one side. And in the fourth image, we can see that there is no malfunctioning, but both the scapula are having an equal alignment. So what is type 1? So generally at rest in type 1, what we see is that inferior angle is dorsally tilted. When we ask the patient to have an arm motion, what does happen? That the inferior angle gets more dorsally tilted and the acromion gets more ventrally tilted and above the thoracic wall. And as we can see in this image, that the inferior angle is more prominent in resting position. So while we ask the patient to elevate the arm, it gets more dorsally tilted and the acromion moves on over the thoracic wall.
Basically, you're getting something like this.
Yes. Yes. Yes.
Yeah.
Type 2, we can see that in type 2, the medial border is more prominent. Just can visualize this medial border is more prominent. When we ask the patient to have a like just protrude hand or wall test, like it gets more dorsally tilted. The medial border gets more prominent. Just it gets more prominent while having a motion with the motion of the arm. Type 3, we generally get a superior border is elevated like, and when we ask the patient to have a motion or elevate the arm, before elevating the arm, they start struggling more before elevation. It goes like elevation like this. It aggravates the shrug before moving the arm. And type 4, we are having a symmetrical motion. At resting position also, the alignment of the scapula is symmetrical. And while having a motion, we have a symmetrical motion of the bilateral scapula. Here we have some orthopedic examination for scapular dyskinesia. Let's go. The scapular dyskinesia test. This is a very effective test. We get it sensitivity like 81.6% and specificity is like 80.8%. So what we do, we ask the patient to have some small amount of weight in their hands, like 3 or 4 pounds, and we ask the patient to have an elevation of the arm. We try to ask it for the three or 4 times generally to get a proper visualization from the back that is the scapula is moving in a symmetrical way or in a asymmetrical way. There is another test like scapular assistance test. In this test, there is a patient complaint of like restricted elevation of the arm or painful recession. So what we do is we just try to stabilize the superior part of the scapula and have a pincher grip like in the medial inferior angle of the scapula, and we just try to assess the movement or assess the elevation of the arm. Like in glenohumeral rhythm, we saw that we having a together we are having a motion of combination motion of glenohumeral and scapulothoracic. We just try to assess this movement. How would you know that this is positive or not? If the patient is complaining of pain while without assistance and the pain goes off or get reduced with the assistance, then we can say that this test is positive. There is another test like scapular retraction test. We just ask the patient to perform like elevation of the arm and just try to have a hand below the scapula. While performing, they are just complaining of pain or not, or we can find any malalignment or not. Just we try to do it. We are just try to cup the upper part of the scapula, and with the fingers we are trying to stabilize the clavicle, and with the forearm we just try to keep it on the medial border of the scapula. We just need to try to stabilize that middle border of the scapula with along with the clavicle, and we ask the patient to elevate the arm. We tested in 3 or 4 ways, like with free of fall, with assistance, and with resistance as well. As we just see if with the resistance the pain increases or not, and with the assistance it is decreasing or not. Any sort of findings we get, like with resistance it increases or with assistance it decreases, then we can say that yes, the scapular retraction test is positive. This is a low row test. Basically, sometimes we find that patients used to make use of lower portion of the muscles, like from the thoracolumbar or lumbosacral region. They need or they take muscle assistance from there to have a motion of the scapula. So what we do is we ask the patient simply to have a simple hand in a neutral position and just to resist the extension of the arm. Second, what we do, we ask the patient to contract the glutes so that we can isolate the lower portion, and same we repeat with the extension of the arm. By this, we just try to examine what are the different movement or difference between all the muscles attached along with the medial on the lower part, along with that, we also get to know it more about the biceps muscle and further triceps muscle. Is there any change with this gluteal contraction or not? If there is any changes in pain, in motion, or in contraction, or in alignment, then we can say that yes, this is positive test. There is another test for the lateral scapular slide test. We just ask the patient to be in a standing position and hand in neutral position. We take the measurement of the inferior angle of the scapula from the mid of the spine. And we can perform in this neutral position, then in a 45-degree of angle of the arm, just resting the arm over the pelvic, and in a 90-degree of arm. We just keep note down the distance or the measurement of the distance between the mid of the scapula, mid of the spine and the inferior border of the scapula in 3 findings. And then again, we compare with the another side. If there is any sort of measurement change, then we can say that yes, definitely there is some dyskinesia is present. We also go for some muscle testings, like we ask the patient to grab just behind the head and have an outward movement of the both arm, or with assistance as well. If both the arms get touched towards the bed, then it's okay, fine. And if it is not in a proper alignment, or if there is any shortening of unilateral or bilateral pec muscles, we can get a restriction, like one arm is getting in touch and other is not getting it, or somewhat like both the arms is stuck, it is not getting more from here. So we can say that in this movement, we can say like the pec muscles are shortened. For the another test, like patient is in a supine line with both the legs half flexed, the arm is fully straight, and the palms is we are just trying to face the floor. We ask the patient to touch the bed, like simply like this. Just we ask the patient to simply touch the bed. If there is any sort of restriction, like this arm is going, this is not going, like this, then we can say that yes, there may be some soldering of the latissimus dorsi. There are some more muscle testing for the rotator cuff muscle, like supraspinatus empty can test. We can register and check how the muscle is working. For infraspinatus, we can check it in just like external rotation in the external rotation, just external rotation in 0 degree of R. And for teres minor, we can do a pat test, like scapular movement or position. We just try to register the external rotation and see how the scapula is showing the alignment. And for the subscapularis, we can have a lift off test. Just we ask the patient to keep the hand just at the back of the side. I hope it's visible. And we just ask the patient to just lift it off. So if the patient is able to do it or not, we can have an overview over the subscapularis is functioning or not. Now we are moving some common nerve involvement. So we can have some neurophysiological changes as well. As we know that the major muscle is like serratus anterior and trapezius muscle has been supplied from the nerve, from the cervical region and from the cranial nerves as well. There is a long thoracic nerve which supplies the serratus anterior. There is a spinal accessory nerve. Can anybody just let me know that what is the root value of spinal accessory nerve?
Can anybody tell us what is the root value of?
And root value of spinal accessory nerve? Anybody?
Anybody can tell us the root value branch of the cranial nerve. That's good.
Yeah.
So which cranial nerve is your spinal accessory? Anybody?
Anybody?
Foundational first year anatomy. 11th cranial nerve.
That's 11.
Yeah.
It is the 11th cranial nerve. Yes.
Okay. Okay.
So
can anybody tell us the root value of long thoracic nerve?
Anybody? Yeah, that's right. This C5, C6, C7.
Okay.
Yeah.
Good. Okay.
So we can just have the assumption like these nerves can have a big impact over the scapular dyskinesia. Like cervical radicular pathway, definitely from the mid or lower part, the neural supply of the scapula may be affected, or maybe we can get an impact over the scapular region. There is one more important nerve, like dorsoscapular nerve. It is a nerve. Can anybody tell me the root value of this nerve? That's right, Dr. Nilima. It is C5, ventral
Let's see.
horn.
Yeah.
Yeah, yeah. So we know that this nerve is supplies basically on the rhomboids and levator. So weakness of this nerve or any changes in the nerve or neurophysiological changes in the nerve can have an impact over the scapula. Regional interdependence. So as we just had a view over, in the previous slides, like cranial nerves have an impact because the spinal nerve supplies the most important muscle for scapular attachment. Like would anybody like to take an attempt once more, though it was mentioned in few slides ahead?
Can anybody tell me what spinal accessory supplies? Which muscle spinal accessory supplies?
Yes,
Trapezius.
yes. Traps, right. So it has a very impact upper, middle, and lower fibers over the scapula. So it is being supplied by the cranial nerve. For the cervical region, we have muscle attachments and definitely nerve supply. So we need to look at the cervical region as well if we found any mal alignment or alteration motion of the scapula. For the thoracic spine and the ribs, we know there is a lot of attachment in the medial aspect and the anterior aspect of the scapula, like rhomboids, sertus anterior. And for the lumbopelvic region, we have a very important attachment. Like anybody like to take a try? What main
Any
muscle?
muscle that comes from lumbopelvic region and supplies the scapula? That's good. That's why,
Lats.
and I think that's an important muscle. I think sometimes we just overlook and not able to make that connection from your lumbopelvic region to your shoulder or your scapular region.
Yes.
But that's important. It's important to understand that you have lat attachment from your
Yes.
SI lumbopelvic region to the scapula and shoulder.
So I have put up some latest research. Let's go. Let's move on to the latest research. This was an article by Gulera and Co. on 2022. Association between the forward head posture and scapular dyskinesia in patients with non-specific chronic neck pain. So they quoted like, it was very important that forward head posture is highly a risk factor for shoulder dyskinesia, scapular dyskinesia. As we see in the image, in the healthy portion, the portion of the scapula is different along with the cervical spine and thoracic spine in compared with the forward head posture. As it is moved up or moved forward, the scapula is bound to move up or in a protracted position. It has to move up. So the bad posture or disorientation of the scapula can have a great impact. So when we are going to treat for the patient like for forward head posture, we have to work for the scapula as well, because only working on the forward head posture is not going to work. This article says that we have to look after the scapular movement disorders as well. There was another article by Telly and Stalgam on 2022, the scapular dyskinesia and loss of cervical lordosis in myofascial pain syndrome and its effects on pain and posture disorders. This article says like if we are working on the cervical loss of cervical lordosis, we have to look for the scapular dyskinesia, because it is very heavily negatively affected the patient with which are accomplished by the scapular dyskinesia. So while making a treatment plan or protocol for the cervical lordosis, loss of cervical lordosis, we have to make a protocol for the scapular movement disorders as well. There was another good article by Bond and Company. It was on 2016. They made a prevalence over the overhead athletes and the non-overhead athletes. They found like the 61% of the athletes who are overhead had overhead motion, basically more motion. They were very easily affected or found with scapular dyskinesia. They made a chart like pie chart. Here they have presented the whole, like all the sports like volleyball, baseball, swimming, handball. They have a good proportion of involvement or present with scapular dyskinesia. This is a very good article to go through. There was another article by Telly and Salgam, same year, 2022, the prevalence of scapular dyskinesia in patient with back, neck, and shoulder pain, and the effect of its combination on pain and muscle shortness. They just quoted in the article like the scapula was a very important component of shoulder kinetic chain. They basically just had a look over the scapula in resting position and in function position. They quoted that we have to have a prescription for the scapular motion for the necessary part like physical therapy exercises and strengthening of the scapular stabilizers for the what we are going to consider for the rehabilitation program. There was another article by Arohan Siasia on 2022. They made the topic was like current view of scapular dyskinesia and its possible clinical relevance. They prepared a chart where they just mentioned all the possibilities how the scapula can be affected. It may be the hip core weakness, it may be the scapular muscle attachments, it may be the shoulder weakness, it may be the tightness, anterior posterior muscles, inferior muscles. It may be a loss of conscious control, like not voluntarily able to retract the motion. Maybe insufficiency of the sertus anterior or trapezius. Maybe the joint involvement, any sort of tear or instability. There may be some sort of fracture, like any sort of deformity or difference in angulation. It can be a neurological as well, as we mentioned earlier, maybe long thoracic or spinal accessories, nerve involvement or neurophysiological changes.
So I think this is a great slide because this sums up the region interdependence. If you look at the effect of scapular positioning, I mean, scapular positioning can be impacted by so many factors, from like hip core weakness. You can have like a scapular muscle detachment. You can have weakness of the stabilizers. You can have tightness of the neck muscles. You can have loss of conscious control. You can have like, we emphasize on testing serratus anterior lower trapezius selectively, like do a manual muscle test of those two muscles. And then you can also have long thoracic nerve injury, and you can have joint dysfunctions anywhere from shoulder, scapula, thoracic spine, and your lumbopelvic region.
Maybe, sir, it may be acromioclavicle or sternoclavicle as well.
Absolutely, absolutely.
There was another article put up by Castellin. Sorry. There was another article put up by Castellin. Just move on one slide. There was another article put up by Castellin and Co. on 2016. Are chronic neck pain, scapular dyskinesia, and altered scapulothoracic muscle activity is interrelated? They made an control study with surface and the fine wire EMG. What they found, like they made a research and they found that there was no link between like age, height, weight, and gender or occupation of the patient. maybe they are present with scapular dyskinesia or no scapular dyskinesia. They found that they had to look off the scapular region if a patient is coming from shoulder pain, neck pain, or back pain. We have to look off and work on the scapular motion, scapular bone. They also found they found that if a patient is having an idiopathic pain, they made a comparison between an idiopathic pain, neck pain, and a control group of a healthy group of people, that they found that there was a higher activity of the pec minor while just they were performing the towel ball slide. They saw that the activity of the pec minor was very high, and respectively in another study they found that the lower middle trapezius activity was very less in the same movement when the patient or patient group were having a neck pain or scapular dyskinesia in comparison with the healthy group of people.
Dr. Amit, do you mind going to like previous slide where we had that pie chart for overhead athletes? Somebody's asking a question. So
yes, sir.
Yeah, if you look at the prevalence of scapular dyskinesia, this is an article published by Burns. You can see that all the overhead athletes, the prevalence was higher for scapular. So volleyball was 30%, baseball was 18%, followed by swimming, handball. When you look at the prevalence of scapular dyskinesia, where in non-overhead sport was less. So they found that scapular dyskinesia is more prevalent in
Overhead
bound to be more prevalent in overhead athletes.
Exactly.
Yeah.
I'll move on, sir.
Yeah, I think this is good. I hope this is, I mean, this is what could be the reason? You tell me what could be the reason. Yes, I mean, if you're overuse, I mean, there could be so many reasons. I mean, Dr. Amit, can you go to the slide where there are possible causes of?
Yes, sir.
Possible causes of scapular dyskinesia. I think move on. Move on to the slide that emphasize on region interdependence. Okay.
Just a moment.
Keep going forward.
Regional interdependence slide.
Yes. Yeah. Yeah. These are the causes, and then there's a slide which sums up the region interdependence.
The charts, sir.
Keep moving. Keep moving. Keep moving. Yeah. Yeah. So people who are overhead athletes, these are the possible reasons why they can have scapular dyskinesia. Okay.
As one more reason, sir. Understand, like, just what I understand is, as we went through the muscle attachments, as we saw, the most of the muscle attachments were above the scapula or just anterior prospect or the posterior prospect. It was very less below. So all the attachments are from the neck region, from the anterior aspect, and for the upper superior part of the scapula. What I think is, just for the overhead athletes, the uses of all these muscles make a very probable reason that there may be they are more probable to having scapular dyskinesia. I hope that answers this question.
If you have rhomboid muscle weakness, you would have higher chances of. It's a scapular stabilizer, so you'll have dyskinesia. Okay, you need to have all the slings working properly. They're prone to more impingement, more prone to, yeah, absolutely. Okay. And they're, yeah, okay.
Okay, so I'll just move on, sir. Sorry. Yes. So there was one more article I found very relevant for all of us. Like, it was by Akodu and Co. in 2018. they made a correlation among the smartphone addiction, craniovertebral angle, scapular dyskinesia, and selected anthropometric variables in the physiotherapy undergrads. What they found is, irrespective of male or female participant, if the addiction of the mobile was more, they had high chances of reduction in the craniovertebral angle, and it leads to increase in the scapular dyskinesia. We had an image for this. Like we can see, there is an angle. It is being made like a horizontal line from the C7 spinous process and a straight line from the teres of the tragus of the ear to the spinous process of the C7. This angle normally it's been like 50-degree. If it is less, then we can assume that this is the forwarded portion and it is more. Nowadays, what we are doing it like we are getting addicted to a mobile. Either in a sitting position, we have a like very stoop posture all time using like this. And if we are going to a bed and taking 2-3 pillows, just we are having a just stoop back, sway back like posture in here. So in both the cases, the angle of craniovertebral angle is getting changed or disturbed. So we can have lot of effects or neurophysical effects over the nerves which are coming out from the cervical region as well as from the cranial, from the brain as well. So it is very important. They found out the addiction should be okay, but they need to correct their angle or posture, which is very important because it will lead to problem with the neck issues as well as for the scapular dyskinesia as well. So deliberately, I just picked up one muscle from among all the 17 muscles of the muscle attachment to the scapula. So the why I picked this muscle, just I explain this. I'm having a small video for the latissimus dorsi. Just look for the video first, then I'll just explain. So this is a triangular shape flattened bottom muscle having lot of attachments or originating from the mid thoracic region towards the up till sacrum. So it originates from the outer lip of the iliac crest, as we see there. And it's also having attachment from the lumbar to the sacrum region, and also from the T7 to T12 spine, from mid thoracic, almost mid thoracic to the whole lot of sacral region. It get attached to all the thoracolumbar fascia as well, and it has attachment to the lower 4 ribs as well. And this broadened muscle, big muscle, having a very small attachment here in the inferior angle of the scapula. And all the muscle gets binds up and fused together, and it gets insert in the humerus, in the intertubercle sulcus or the bicipital groove. So this muscle is covering a large proportion of the posterior trunk and having a very small attachment in the humerus. Why I found this important? Because as we see, the muscle is having a very small portion of attachment to the scapula and covering a lot of area from mid thoracic to the lower part up till sacrum, and even in the innominate also, like pelvis. For the iliac crest. And this big muscle is being supplied by the thoracodorsal nerve, which root value is like C6, C7, C8, as I've put up on the slide. It originates from the mid lower cervical region. So we can assume that it's not necessary the scapular inferior angle if it's prominent, though it is very common findings among all the types. So it will be only affected in the scapular region. It can get affected in the mids lower cervical region as well as in the lower thoracic or the lumbopelvic region as well. So we need to have a broader area. If we get any sort of dyskinesia, any sort of malalignment or alteration of the motion of the scapula, we have to look at the extreme above end and the extreme below end. It might be the muscle, it might be the nerve. So we have to look at the broader area, why there is a, or what are the findings may be possible.
So I think summing up what Dr. Amit is saying, that I mean, your cervical roots can impact latissimus activity, and that can cause scapular dyskinesia. Your restriction in your thoracolumbar region, especially your lower thoracic, upper lumbar, mid lumbar, lower lumbar, can impact activity in the latissimus dorsi. It can also be impacted by lumbosacral region. And I think how many times we see patients with shoulder pain, with signs of scapular dyskinesia, having low back pain. So the idea is, when you're treating patients with scapular dyskinesia and shoulder issues, and you're suspecting latissimus to be a problem, do assess the back.
Yeah.
Okay.
So what is the action of the latissimus dorsi? Basically, we know that we are having an adduction. When adduction, we are having an internal rotation and extension of the arm. Along with this, it gets an impact over the inferior angle of the scapula. It pulls the inferior angle of the scapula in various direction. So definitely, along with all the arm movements, it is having some sort of impact over the scapular region as well. So while working on scapular dyskinesia, we have to work over the latissimus dorsi as well, because basically for this muscle, we get more findings in the shoulder region, shoulder joint, or in the lower part of the trunk, like thoracic, lower thoracic, or lumbopelvic. But we need to look, if we get any sort of malalignment or alteration in the movement of the scapular bone, we have to look for these areas as well. So this is the logarithm, treatment logarithm. It has been quoted by Ebecker and Kuhl in 2010. They found that while making a treatment protocol for any segment, like any regional interdependent segment, maybe cervical, thoracic, shoulder, or back, we have to work for the scapula as well. We need to work on the strengthening. We need to work on the mobilizing. We need to work for the neuromuscular coordination and strengthening as well. So this leads to, like, for every part, like for neck, for thoracic, for lower part, or pelvic as well, we have to look for the scapula as well. Because if we just exclude the scapular region, it might be that we are not going to get a satisfactory result, because all are interconnected, as we see. So working on the lower part, we need to see the scapula as well. Working on the cervical part or working on the scapular shoulder part, we have to work for the scapular region as well. So this is also a great article. If anybody want to access, just I can share this in the group. So some exercises and treatment, like for the muscle weakening and imbalance, we start exercise in slow progression and we go for the high levels. I have quoted some exercise like the I, Y, and T. Just we ask the patient to lie in a prone line, just to have I-like movement like this. For Y is like with this in a prone line, and for the T, like just simply lifting the arm. And we can make a progression like 5 count, 10 count for 3 to 5 repetition initially, and again we can progress like for 10 to 15 or 20 repetitions as well. Some more exercises, we can use it like TheraBand as well. I use generally Thera loop. This is very helpful for me, just like the exercise which has been shown. Simply for all the directions we can use it, fixing one arm and doing the with the other arm. Some more exercise with TheraBand, with long arm stretch. Just we can grab it for the wall in his line. We can use this exercise with the roller also, just gliding simply over the wall. slowly. We can have some grab and pull, like just we can fix it in a area. Just simply we are going to pull it and hold it for 10 count. Usually we can start with 5 counts, then we progress to 10 count, maybe 5 repetition or 10 repetition. We can fix it in the any sort of hook like in a door, and simply keeping the hand straight, we pull it down just to activate the muscles, the stabilizers of the scapula, the stabilizer muscles of the scapula. I also use a pilot ring. I usually start with this ring as well, usually just to have a isometric contraction in all the respects. Pull it out and hold it. Just simply go up and down. So slowly we can make more progressions accordingly. So that's it. These are the references.
Do you guys want us to explain anything or repeat any slides? Please just let us know. Okay. Anything you want us to review again, just let us know. I think this was a very well prepared presentation. Can you go back to the protraction slide, Dr. Amit?
Yeah, sure, sir.
And you can review the exercise part again. For serratus anterior, you can do like some wall slides with the foam, with the band. Okay. You can do like a supine punch. In supine lying, you can do like a punch. Okay. Okay.
Protraction, right?
Yep.
This is the
What is the role of manipulations? I think manipulations can impact. So for example, I'm going to give you this example. I mean, I think this is a good example. So, and this is for people who have attended our courses in the past. So we always talk about like lumbopelvic or lower thoracic impacting latissimus activity. Okay. If your latissimus is hypertonic and you're finding like a true latissimus shortening from side to side, okay, you can definitely assess lumbopelvic region, you can definitely assess SI. Sometimes manipulation can reduce the activity or can create like down regulatory effect on the muscles also, can reduce the hypertonicity of the muscles. And in certain situations, you might see improvement in range of motion right away. Okay, so if somebody has decreased elevation of shoulder and you're finding that patient also has like low back pain, okay, and you're finding latissimus hypertonicity or true shortening of the latissimus muscle, by manipulation to the lumbopelvic region or manipulation to the SI region, you can definitely influence the activity of the latissimus. And that's what Dr. Amit was talking about when he was showing you the video. Because the attachments are so widespread that when you're finding latissimus dorsi, and that's why he picked latissimus dorsi, because the emphasis is that your scapular dyskinesia is only a small component, but it can be influenced through various bodily segments. It can be influenced through cervical roots. It can be influenced through thoracodorsal fascia, via getting influenced through restriction in the lower thoracic and lumbar region, getting influenced through position of the innominate, getting influenced through absolutely. I mean, anterior innominate can cause false shortening of the latissimus. So yeah, I mean,
orthos can also
you can do like muscle energy techniques. Some people like to do manipulations depending on what your skill set is, and you can definitely calm down that latissimus.
torsions also can play a big impact. Torsions.
Yep, torsions can have a huge impact. Tapping is helpful, maybe temporarily, but if there is an underlying joint issue going on, you have to address the underlying joint issue. Like if there is a true positional fault, if you have anterior nominate rotation, as Dr. Manoj is saying, or you have like a sacral torsion is going on, which is with sacral torsion usually happens with anterior nominate if you have a symmetrical sacral torsion. Weakness or overuse of any scapular muscles can cause dyskinesia. That's a beautiful explanation. So that's why, I mean, I don't want to exaggerate the issue, but I think Dr. Amit was talking about omohyoid. So a lot of osteopaths do like a hyoid mobilizations, and that can impact the scapular positioning. I don't want to go digress from the issue. Pectoralis release, you can do IASTM temporarily will help, but usually your rib dysfunctions can impact, your costovertebral rib dysfunctions can impact the activity in the pectoralis muscle. That's an interesting observation. The patient has a lot of scapular muscle weakness, and wherever we go for trap stretching, I see involuntary scapular. Yeah. So omohyoid is a muscle that attaches the hyoid bone to your scapula. I think we don't talk about hyoid mobilizations in our program, but we do talk about how position of the hyoid bone can be impacted if you have TMJ issues, if you have upper cervical issues. So that can also impact the position of the scapula. Okay. What can be a reason if he has whiplash history injury and not that severe it was? I mean, whiplash is a totally different science. I think we can have a 1 hour lecture on it, but we do talk about whiplash injuries, how it can affect coordination of your neck, and how you should assess whiplash injuries differently. We don't even call it whiplash injury anymore. We call it whiplash associated disorders. And we do talk about this in our cervical spine module in a greater detail, because some of the research that has come out for whiplash is like very, very recent. So, and to be honest with you, still learning about whiplash. Latissimus dorsi test. So, I mean, the basic test to do check latissimus dorsi is all you do is either you can do this, or you can do just check side to side difference. Okay. Check side to side difference, because I think if you have restriction in the latissimus dorsi, it will show you. I mean, you can test this or you can test this. Okay. Okay. And all you're trying to do is compare hypertonicity, or you're trying to compare muscle shortening. And hypertonicity will give you like kind of relative muscle shortening. Okay. Yeah. But the idea is to look like beyond. If you're finding scapular dyskinesia, just don't focus on the scapula. There are like widespread muscle attachments. If the patient has a problem with flexion and abduction, no neurological. I mean, I think first you have to find the diagnosis, why the patient has flexion and abduction issues. I mean, and frozen shoulder is a different diagnosis, and we talk about how you can address it, what the research is, and how you should work on rotator interval capsule, and that's a different science. Can you show that slide again where you talk about craniovertebral angle? I think that's a great slide. Yeah. We'll have this video on, or this presentation on YouTube, so you guys can have a look at it, because some of the research in it is very, very recent. And I think Dr. Amit really worked hard to demonstrate like very, very recent research. So just go on that craniovertebral angle slide. Yeah. Yeah. So this is a good slide. And yeah. You can isolately stretch pectoralis minor. I don't think you can isolately stretch pectoralis minor, but you can definitely do needling for it. I mean, and check for third, fourth, fifth rib if they have any underlying costovertebral dysfunction. Yeah, I think Dr. Steve likes to needle pectoralis major minor muscle. I think he talks about that. But I like to address like underlying costovertebral issue. Does craniovertebral?
Yes. Can have.
Yeah, it can. I mean, technically it can. You have muscle attachments, right? So yeah, technically it can. But I think the point Dr. Amit was trying to make is trying to correlate scapular dyskinesia with other bodily segments, and uh, all the flexor weakness. I think you can share this case study on the group, and we'll have a discussion on it. Okay. What is the normal cranial vertebral angle, Dr. Amit?
Around about 50 degree of angle.
50 degree, 49 to, I think
49.9 it
49.
is being quoted. I'm just making in a whole way.
Still
49.9,
not.
but 50 degree.
Yeah, you can share your case study, and please add all the details so that we can comment on it once we know all the details. Because I think once you're talking about scapular dyskinesia, yes. Once you're talking about scapular dyskinesia and then other time you're talking about frozen shoulder, those are totally different diagnoses. So just share the case study, detailed case study on the group, and we can have like a kind of a discussion on it. And I think everybody can contribute to the discussion. Okay. Yep. I think we can share on the group or we can share it on the group and we can have a discussion on it. Yeah. Dr. Can you move on to the last slide? We just want to share that information with the group. So guys, we run this 1-year program and we are starting our cohort. CT manipulation and mid-thoracic manipulation can change the cranial world. I believe so. Okay. Yes. We do treat forward head posture. We do treat cervical thoracic issues by manipulations. Yes, absolutely. Over the period of time with combination of manipulations and exercises, yes, you can impact cervical forward head posture. So we are starting cohort 2. I think our first course starts on 16th and 17th of December. Yeah. And if you want to join in, if you want to be a certified expert orthopedic manual therapist, or you want to be a diplomat of expert manual therapy, which is a more detailed program, you have to attend hands-on training and you have to go through a very, very rigorous exam. If you're interested in learning more, you can join us. And me and Dr. Steve run this program. We are both fellows of American Academy of Orthopedic Manual Physical Therapy, board certified by APTA. Yeah. Yeah. If you guys have any questions, we do teach 2 more free labs next weekend. Dr. Jinke has some interesting stuff to discuss with you. I mean, about role of thoracic spine, or role of thoracic mobility. And Dr. Hassan is discussing a very, very interesting topic on lateral hip pain. Yeah. Great presentation, Dr. Amit. I mean, if you want us to discuss again, I think we'll stick around for 5-10 more minutes. Yeah. If you have any questions, if you want us to discuss again, I think we can. Okay, we are not in a hurry. But this presentation will be on YouTube and you guys can have a relook at it. I mean, some of the slides are very, very interesting because they talk about different aspects of care, trying to connect scapular dyskinesia with a very, very well put up presentation by Dr. Amit. Okay. I've done this for a long time, and every time we do it, I find like I learn something new. And I think Dr. Amit has taught us something new here. So thank you, Dr. Amit.
It was very interesting preparing this slides. I also came across very new things, which I didn't knew maybe. So yeah. I'm also learning a lot of stuff.
Yeah. Guys, if you have any questions, feel free to share them. I think we'll probably leave in like 5 more minutes. If you have any final questions, I mean, I think we'll address that. If you have any patients you want to discuss, you can always share it on the group and we can have a constructive discussion, trying to find answers to your questions. I mean, the idea is that we need to look at the recent research and what research is. Well, that's a good point here. I mean, can't scapular dyskinesia is affected pump and handle and bucket handle movements of thoracic movement? Yeah, I mean, absolutely. I would say so. Yeah, I would say so. And I think once you look at the research and once you start learning this stuff, the level of complexity sometimes you come across when you're treating patients with any diagnosis, and in this situation, scapular dyskinesia, you can have multiple bodily segments affected. And we know that there are enough muscle attachments that are coming from your ribs to your scapula. And if you have affected pump handle, bucket handle movement, those muscles can impact the resting position of the scapula, as well as affected motion of the scapula. Okay. Okay. I think that's a good time to leave. I think if you have any more questions, I think you can share it on the group. I think it was a very well prepared presentation. Thank you, Dr. Amit.
Thank you, sir, for your help.
How are we going to assess this and say that it is affected? I think you need to look at, you can compare side to side, and you need to look at the normal video one more time. You need to look at the normal video one more time. Once you know what the normal is, you will be able to assess abnormal, and you can run bunch of tests. The test Dr. Amit was talking about. Okay, you can run bunch of tests, and then don't make your analysis just based on one test. Okay. Okay. And we'll share this video on the YouTube, and so you can have relook at this video, relook at the slides. Okay, run bunch of tests, and I think that will give you information. We always emphasize on not making a diagnosis by just one test, because no test is 100% sensitive or 100% specific. So make sure that you run cluster of tests, so the diagnosis you're finding is accurate. Okay. And if you have any questions, I think feel free to share it on the group. Yeah. I think that will be it, Dr. Amit. Thank you for all the work you did. I mean, I think it was an amazing presentation, very, very detailed.
Thank you, all of you, just
Thank you, guys.
listening us and giving the opportunity for just presenting this very innovative and new research articles. Thank you, everyone.
Thank you, guys.
Thank you.